Assalamu alaikum. Today we will discuss on the chronic diarrhea in detail. That how we have to, what is chronic diarrhea, what is the persistent diarrhea, and how we have to approach to lay down our diagnosis in differential diagnosis in chronic diarrhea, what investigation, and finally we have to discuss celiac disease in detail. So, in last lecture we discussed diarrhea as increased fluidity, volume, and frequency of stools relative to the usual habits of the individual. 3 or more loose watery stools is stored as a acute diarrhea. Great majority of diarrhea episode lasts less than 1 week. When diarrhea persistent more than 14 days, it is called persistent diarrhea, intractable or chronic diarrhea. This is the last acute diarrhea. We discussed some dehydration, severe dehydration, no dehydration. Now, this portion is remaining that I told you that we'll discuss in the persistent diarrhea. So diarrhea which is remain 14 days or more than 14 days is the persistent diarrhea. And what is the severe persistent diarrhea? In persistent diarrhea, when there is a dehydration, you label as a severe persistent diarrhea. When there is no dehydration in duration more than 14 days, then this is the persistent diarrhea. And if it is blood in the stool, then you call it as a dysentery. So what is severe persistent diarrhea? Diarrhea which is prolonged than 14 days with the dehydration is the severe persistent diarrhea. Diarrhea more than 14 days with no dehydration, this is the persistent diarrhea. And if there is a blood in the stool, then you label as a dysentery. And chronic diarrhea in developing world, persistent diarrhea usually follows an acute episode and typically associated with a serious infection without the time to recover between episodes. Children risk of malnutrition and often other integrating phase. So in the developing world, like in Asia, Bangladesh, India, Pakistan, Afghanistan, they have a more infective diarrhea, and then again cycle of the recurrent diarrhea lead to the malnutrition, and malnutrition by itself lead to the chronic diarrhea. But in developed countries, there is a less viruses and bacteria infection, so there is less chances for the chronic diarrhea, and they have a less chances for malnutrition. And if they have a diarrhea, which have a chronic diarrhea, then everybody have to think that this either is a food allergy or the celiac disease in developed countries like USA, UK, Canada. Diarrhea is the second leading cause after the ARI. Then now we have to discuss the detail what are the causes of chronic diarrhea. One is the inflammatory causes like tuberculosis can lead to chronic diarrhea, eosinophilic gastroenteritis, Crohn's disease, necrosis, enterocolitis, allergic colitis, enonchal vasculitis, malabsorption stress, pancreatic disease, cystic fibrosis, Diamond-Schwarman syndrome, Crohn's pancreatitis, hereditary pancreatitis, congenital lactase deficiency, congenital trypsin deficiency, liver disease like cholestatic jaundice, primary bile acid malabsorption, intestinal disease like tropical screw, celiac disease, Whipple's disease, intestinal lymphangiectasia, A-beta lipoproteinemia, enterokinase deficiency, lactase deficiency, considered acquired, we discussed last lecture, sucrase isomaltase deficiency, glucose, galactose malabsorption. Then aminodeficiency can have a presentation of chronic diarrhea like A-gamma globulinemia, isolated Ig deficiency, combined aminodeficiency, they can lead to the chronic diarrhea. And then age-wise, if we divide infancy, childhood, adolescence, and infancy, there is a most common cause is post-gastrointestinal malabsorption syndrome, which can persistent. Cow milk or soya protein intolerance in infancy, secondary disaccharides deficiency, cystic fibrosis. These are the causes which can lead to chronic diarrhea in infancy. Then in the childhood, chronic non-specific diarrhea or toddler's diarrhea, which is the diarrhea which happen in the 3 to 4 years. The child is not able to chew, they have to swallow, and like vegetables, carrots, and pea and others undigested vegetables pass into the stool. That is the benign condition, and it uh, will disappear after the passage of time after 1 to 2 years when the child will start to the chewing. So this is the toddler diarrhea. The parents are too worried that they have all that is taking and is coming in the stool. Then in childhood, there is a secondary disaccharides deficiency. Giardiasis is more common in childhood. Post-gastroenteritis malabsorption syndrome like celiac disease, cystic fibrosis, along the chest, they have a malabsorption also. Adolescents, 10, 12 years, 13 years, it can be caused can be irritable bowel syndrome, inflammatory bowel disease, Crohn's disease, ulcerative colitis, giardiasis, and lactose intolerance can happen in adolescents. And then one of the causes infectors also. There's bacteria like Salmonella, Campylobacter, antibiotic induced. The prolonged use of antibiotic can lead to the antibiotic induced Clostridium difficile. Then post-infectors like secondary lactase deficiency, parasitic giardiasis, scariasis, amoeba, mycostoma, they can lead to the cause of the chronic diarrhea. And this is the diagrammatic presentation. All causes like infectors, we discuss bacteria, viruses, parasite can lead to chronic diarrhea. Then endocrine hypothyroidism can lead to the chronic diarrhea, adrenal insufficiency. Then chronic non-phys diarrhea. Carbohydrate malabsorption can lead to the chronic diarrhea, lactase deficiency, glucose, galactose malabsorption. Dietary cow's milk, soya protein intolerance can lead to chronic diarrhea. Immune defect like we discussed, hemoglobin, Ig deficiency, AIDS can lead to the chronic diarrhea. Metabolic like familial pancreatic chloride diarrhea, watery profuse diarrhea from the birth can happen in the familial chloride diarrhea. Then pancreas can involve in the cystic fibrosis, hematitis, celiac disease, and in adults, we discuss IBS, irritable bowel syndrome, inflammatory bowel disease. These are list of the causes can lead to the chronic diarrhea. And how we have to approach and to differentiate between the these all causes. So very difficult. We have to go into the detailed history and the examination to dig out that what is the one cause of the chronic diarrhea in the child. So history is very important to diagnose the chronic diarrhea. What is the age of the child? Duration of the diarrhea? It's 10 days, 15 days, 1 month, 2 months, 6 months. Consistency of the stool, is there a blood, mucus, or pus in the stool? The stools are offensive, non-offensive, they have a smell or not, frequency, how it is frequent, volume, it is small or bulky, associate symptoms with the diarrhea, if they have vomiting, fever, abdominal pain, tenesmus, convulsion, cough, appetite, pet pause, heat intolerance, and hypothyroidism, tremor, and hypothyroidism, type and quantity of milk and fish. The child, which type of is mother milk, or is it top-fed milk, what is the dilution of the milk, how much quantity of the milk we are giving, or they have a mixed mother milk or top-fed is there. Food, what type of the food the child is preferred to eat, or the parents are giving to the child. Allergy to fed food, like in family, if they have allergy, then there's chances that other child can develop past severe attack, how frequent, in detail, past medical, surgical history, any surgery in the abdominal surgery or bowel surgery that can lead to the chronic diarrhea, small bowel is there. Family history of similar condition, like they have a celiac disease in one child in the family, there is a chances for the second child have a chronic diarrhea. We have to exclude the that cause celiac disease or cystic fibrosis, or lactose intolerance, or lactose deficiency, lactase deficiency. Living condition, always we know that poor and low socio-economic, they have a more have an infective causes. So we have to go into detail that what are living condition of the family. Drug history, if they have taken antibiotics, they can lead to the drug-induced diarrhea. Travel history, they have to travel in near past. Then there is some points to differentiate that the small bowel diarrhea, large bowel diarrhea. That what is the volume of the diarrhea? If large volume will be in the small bowel involvement, and is there blood or not? Blood will be usually present in the large bowel diarrhea. colon if they will involve. Rectum symptoms will be in the large bowel. Steatorrhea, greasy stools will be in the small bowel. Very difficult to flush out greasy stools that will be in the small bowel, like in celiac disease. Excessive flatulence due to the carbohydrate malabsorption, it will be there in the small bowel, not in the large bowel. Protein malabsorption, if there, then they lead to the pedal edema. Edema will be in the small bowel involvement, not in the large bowel. And pain, abdominal pain, it will be in small bowel, will be peri-umbilical, and it will be not decrease after passing of the stool. But the pain in the large bowel will be hypogastric, and it will be decreased after passing the stool after defecation. The pain will be relieved in the large bowel. Color of the stool will be pale in the small bowel involvement. Smell of the stool, which will be offensive. Foul smell in the small bowel. Vitamin deficiency will be more frequent in the small bowel involvement than large bowel involvement. So these are the some different features in that small bowel are large bowel is involved. Then there is a physical findings. These are that when there is malabsorption, there will be nutritional deficiency like calorie, fat, protein, weight loss will be there, malnutrition, protein loss will be edema, and hair loss, iron, folic acid, vitamin B12 will be anemia will be there, nicotinic acid will be glossitis, dermatitis, vitamin B, B12 will be paresthesia, erythroneuritis in the patient, vitamin K will be bruising, potassium, sodium, magnesium will be body weakness, calcium, fatigue, bone pain, zinc will be hair loss will be in the child will be malnourished. Pancreatitis will be abdominal pain, celiac disease, you have to associate with the chronic diarrhea fever, dermatitis, herpetiform, skin involving mouth ulcers, and skin itching skin, Whipple disease associated with polyarthritis, skin pigmentation, and then with the biliary involvement, with sometimes cystic fibrosis, liver involved, jaundice will be there. Post-gastrectomy, scar, any surgery will be there. Inflammatory bowel disease like chronic bleeding, diarrhea, abdominal pain, intra-abdominal mass, Crohn's disease, fistula, and structure, manifest arthritis, stomatitis, gangliopyedema, epistaxis, toxin, can be complications. So the large bowel, inflammatory bowel, Crohn's, ulcerative colitis will be bleeding, and other extraintestinal manifestation can be there in the chronic diarrhea in the IBD. Then examination, you have to go for general appearance of the child, mental status, vital signs, respiratory, heart rate, blood pressure, growth parameters, height, length, weight, FOC, that you have to decide that child is short stature, failure to thrive or not, hydration, if the child is with the persistent diarrhea, dehydration or not, if the dehydration is persistent diarrhea, severe persistent diarrhea, and then volume duplication autoimmune involvement is there or not. And anemia, pela, exophthalmia, hypothyroidism, upper cells will be there in the inflammatory bowel disease, and celiac disease, lymphadenopathy, malignancy, infection like tuberculosis, the chronic diarrhea, the lymphadenopathy, diabetic for tuberculosis, lupus disease, 3-4, their lymphadenopathy, thyroid examination very important, their hypothyroidism, clubbing will be there, liver disease, inflammatory bowel disease, laxative, and celiac disease will be clubbing there. Skin lesion, dermatitis herpetiform, celiac disease, erythema nodosum, pyodermatitis, and the examination in the inflammatory bowel disease, hyperpigmentation, chronic diarrhea in the additional disease can be there. Abdominal examination, you have to look for the chronic diarrhea, surgical scar, abdominal tenderness is there or not, mass, any palpable appendicitis in disseminated tuberculosis. Auscultation, you have to, is there a rapid transit time, or there is a paralytic ileus. Peridial rectal examination, ulcer, fissures, abscess, fistula, stenosis, very important regarding the inflammatory bowel disease, ulcerative. This one more in the both in the Crohn's disease and ulcerative colitis. Systemic examination, you have to do chest examination, that types like tuberculosis, joint arthritis, local disease will be information of joint examination. Then you have to go into the investigation, narrow down your differential diagnosis. First, you have to go for the CBC, tell that they have hemoglobin, anemia is there, pancytopenia, or they have a neutrophil lymphocyte like immunodeficiency, you have to look for detailed, complete blood count. Stool culture, the stool DR, stool culture will tell that cause or if they have a fat malabsorption or carbohydrate malabsorption. Electrolytes, you have to look for renal function test, endoscopy, colonoscopy. Endoscopy, you have to go for get the biopsy, like if the celiac disease, or you have to look for the Crohn's disease biopsy. Colonoscopy, especially you have to go for the ulcerative colitis. Thyroid function test, in the hypothyroidism. You will not go all investigation in one patient. You narrow down in the history examination, differential diagnosis, then you have to go for specific ways. This is the baseline and then specific for the disease. Antibody test for the celiac disease, sweet chloride test for the cystic fibrosis, trial for lactose restriction, or you to go for lactose breath test, stool for reducing substance for the rule out for the lactose intolerance. This is again some details that how you have to specify that protein or carbohydrate absorption in the stool DR. You have to go macroscope stool like it's a mucus blood is there. The presence of fat is a quantitative or qualitative. You go for the qualitative, you go for Sudan test. It will tell you the fat will absorb fat insufficiency. Proteins, you have to go for specific right for alpha-1 clearance. Carmitrypsin, calprotectin lastase, this for the proteinose enteropathy, pancreatitis, and stool pH is important. The acidic less than 5.5 thing called carbohydrate absorption. And if the stool reducing substance is positive in the stool, then this is the lactose intolerance. So you will look for glucose, galactose, and lactose absorption for the cause. You will identify the cause. Osmolality will tell if they have more than 250 is osmotic diarrhea, less than 250 is diarrhea. Stool culture will tell infectious cause. Look for the fresh view of the stool, microscopy, parasite can be visible here. Ocular blood will be there in the inflammatory bowel disease, infected diarrhea, protein sensitive syndrome. Now we have to detail the most common cases we found in the chronic diarrhea is the celiac disease. After the tuberculosis is the celiac disease. Celiac disease is the gluten enteropathy or wheat intolerance. Have to see patients in family or have missing that in this disease you have to stick the gandham. Gandham you have to stop. Okay, this is the only treatment for the celiac disease. You have to give the gluten-free diet. So, what is the celiac disease? How we have to diagnose treatment? You know that you have to stop the wheat. What is the celiac disease? The abnormal semantic mucosa due to the intestinal reaction to the gliadin, the component of the gluten. Etiology is autoimmune disease in which alpha gliadin is recognized. This is whether the autoimmune disease with the celiac disease you can form the thyroid disease. Can be hypothyroidism or hypothyroidism in associated celiac disease. Gluten is a protein in the celiac grains, is a toxic factor. Associated genetically, it can be associated with the HLA-DQ2 and HLA-DQ8. So combine this, a multifactor like genetically we discuss HLA-DQ2, DQ8 are immunocompetent antibodies specific to the dietary protein, and then gluten alcohol soluble component with the wheat, rye, barley protein. They have a protein that against for this protein antibodies develop and lead to the damage to the intestine and the chronic diarrhea. This is the healthy intestine wall. Healthy normal biliary small intestine is under microscope. And this is when that gluten or wheat is given when complementary feeding is start in the child from 4 to 6 months. Child take the like biscuits or wheat or celiac wheat, celiac of the wheat. So starting our meal after wheat, then starting damage. It takes few months damage. Villi of the small intestine will be look like this in the celiac disease. So what will be clinical features in celiac disease? There will be chronic diarrhea, classically, along with they have a weight loss, anemia, vitamin mineral deficiency, failure to thrive, not gaining weight, short stature, and they have a more bloating, abdominal distension, gaseous abdomen, Iron deficiency will be here, and they will improve. You go for the gluten-free diet, and litodes and gluten. Again, you have to give reintroduce. This is usually more severe in the proximal bowel. Therefore, there will be iron, calcium, folic acid deficiency will be common in the celiac disease. And what are the symptoms of the celiac disease? Like stool mass will be large, bowel, bulky stools, vitamin K malabsorption is there, protein malabsorption, diarrhea, vomiting, nausea, abdominal pain, weight loss, weakness. These are all our features are others than this, then short stature, anemia. There is the other way of the presentation of celiac disease. And this is the skin manifestation. Like dermatitis, herpetiforms, skin manifestation. 90% have no GI symptoms. Only they will have the skin manifestation will be there. So there will be no chronic diarrhea. Like we know that in the chronic diarrhea they are using for celiac disease, but here in 90% chance there will be no diarrhea. There will be only skin manifestation. There is the other two types, that is variant of the celiac disease, that is the silent and latent celiac disease. What is silent celiac disease? In which there will be blood test and biopsy, small bowel will be positive, but there will be no symptoms. Like one child have diagnosed celiac disease, went for the screening, for they have no symptoms in the other child, but they have a blood and biopsy is positive. They have no symptoms. Maybe they have developed symptoms in future, or may they not develop. So this is known as the silent celiac disease. Another is the latent celiac disease, in which what will happen? There will be blood test will be positive, but there will be no clinical symptoms and biopsy will be negative. So this is known as the latent celiac disease. Then there is some differential diagnosis. We already discussed this. The celiac disease are including bowel symptoms. You have to think for lactose intolerance, pancreatic insufficiency, soya protein intolerance, autoimmune nephropathy, bacterial growth, Crohn's disease, immunodeficiency virus nephropathy, and infected gastroenteritis. Like giardiasis is one of the close differential with the chronic diarrhea and the celiac disease. Then how you have to diagnose? There is some supportive and specific test for the celiac disease. Supportive test is that you install via go for the cytoria, fed more than 7%, 72 hours collection, low levels of ferritin, iron saturation, calcium, ferrous, albumin, cholesterol, B12, absorption will be low in the because small bowel is involved. All that is absorbed in small bowel. Then there is a serological test, it's a specific test in the transfer antibodies for to diagnose for the celiac disease. This will already told that you want to fecal fats, more than 7% will be involved in 72 hours. These are different antibodies that you can go for serology for the celiac disease. And out of that, most sensitive with the anti-tissue transfer antibodies, IgA and IgG. This is the most sensitive, and you can go for any age, and it is available not in all laboratories. It's available in the Aga Khan and other big laboratories, but not routine other laboratories. It is available. It's expensive, costs around 4,000 to 5,000 that you have to go for. And there's the other antibody like anti-indobase antibodies, IgA, anti-D-amine glide antibodies, anti-glide peptide, and anti-glide antibody IgG and IgA. This is especially if you want to go for under 2 years. So out of these, this one is the more specific, and routinely we go for this one. It's available in all laboratories, big all laboratories, anti-trans antibodies, IgA and IgG, most sensitive. Then gold standard diagnosis for celiac disease, the small bowel biopsy. Go for the by the endoscopy, you take in the duodenal or upper bowel biopsy and go send it for the pathology, and it will show that it will be villus atrophy, crypt hyperplasia, and increased number of plasma cells in the lymphocyte hematopoiesis. So pathologists will look for the biopsy if these findings is there: villus atrophy, crypt hyperplasia, increased number of plasma cells, lymphocytes in the hematopoiesis, then this is the diagnosis for the 100%. So this is the gold standard for the celiac disease is biopsy and histopathological diagnosis. Then supportive serology, IgA, IgG. Then finally, the treatment of celiac disease is the gluten-free food, gluten-free diet. So what will be gluten-free diet? Avoid barley, rye, wheat, maybe oats, because it can be contaminated with the wheat. So only you have to give the starchy foods, rice are safe. And then supplementation, you have to give iron, folate, B12, because they are deficient patient in anemia. You can give multivitamin, zinc, iron, folate to increase the hemoglobin level and reduce the deficiencies which you have here. So gluten-free diet is not easy that advise gluten-free diet. You have to go into detail, sit with the family, with the child, if they have older child, because celiac disease, sometimes we diagnose like 10 years, 8 years, 12 years, sometimes 13 years. It's not undiagnosed cases more and more because nobody think for the celiac disease. So if the child is big child, you have to sit with the mother and father and explain that you have to avoid the gandam, wheat, and then if you, it's not only that you stop the this gandam ki roti, tadka ji bani wo band karniya, but you have to explain that, describe that this one medo, you remember that stars, this one this what you call this meda, from where that is सयूं सवैयाँ और ये सारी चीज़ें जो बनती हैं that all from the, या जो मिठाई की चीज़ें या बेकरी की चीज़ें वो सारी मैदे से बनती है. तो मैदा is myself from the wheat. So जो मैदा है that all you to stop all bakery items. So all explain them that you have to not to give the child all bakery items, all that sweets like मिठाई की दुकान में जो भी चीज़ें बनती हैं, all that mixed with the मैदा. So you stop that one. You stop pakoda, samosa. These also sometimes this, especially they are made by the this one besan, but there is some outside mixing of the maida with the besan. That's why you have to stop. Ask them to not to give pakoda, samosa. Then chips also. Chips with the you think that this is the potato chips, but they have a outside they have a powder of the this one मैदा. So chips, टाफियाँ जो भी हैं वो भी बंद करनी है. सवैयाँ, I told you, cone ice cream, this is also that one you have to stop. Cone ice cream is made by the outside, is made by the wheat. Other ice cream can be taken. So all that sit with the family, explain them this, all that you should stick. And this is not for the few months. Family sometimes think that this is for the 6 months, 1 year. No, this is for lifelong. Gluten-free diet food is for lifelong. Lifelong, you have to stop wheat की रोटी, गंदम की रोटी, बेकरी की चीजें, मिठाई की दुकान की चिप्स, टाफियाँ, सवैयाँ, कोन आइसक्रीम, all that one, whole life. Very difficult. When you are constantly sitting with the child, with the family, there will be refusal. When you start, there will be refusal. They will not follow you, but with the passage of time, they will agree. Because when you explain them that you have to stop these items, when they will stop, there will be child condition will be improved. Because the patient who is celiac disease have a chronic diarrhea, they not gaining weight, they have a short stature, anemia, they become tired. So you tell them that this is the treatment, only restriction of the gluten and gluten containing foods. You explain maybe few visits, then again they will be accept, because always when they for the chronic illness they have a refusal may start. So you too, if you have a good counselor, sit with the family, give time to the family, and listen their worried, counsel them properly, they will follow you. Okay, so and what the foods you have to advise that what the child can take, they can take the rice. Okay, they can makai they can take, and चावल की रोटी खा सकता है, ठीक है. Other all vegetable, fruits, mutton, गोश्त, दालें, सब्जियां, और जो है दही, everything they can take, except only that the things which is made by the gandam and the maida, all that is just for the whole life. So prognosis, if it is untreated, undiagnosed, then associated with this for lymphoma, carcinoma, including small bowel and colon. So these can be avoided if adhering to the diet. So we explained in the counseling that if you not stop eat, the patient in the future life can develop carcinoma, lymphoma of the small bowel and the colon. So lastly, we can explain this also, that if you restrict whole life this one wheat and containing foods, child will be normal, will be no anemia, height will be normal, all parameters of the healthy life in the child look like healthy. If you give this wheat and wheat containing, child will be shortest stage anemia, will be there, recurrent abdominal pain, chronic diarrhea, abdominal distension, general condition of the child will be not good. So this all that one we explained to you in the counseling for the celiac disease. Thank you. For any question? Unmute कीजिए. Hello. Hello. Gee, anybody have any question, query regarding chronic diarrhea, celiac disease can be asked one by one.
सर सीलिक डिजीज जो है वो हेरिडिटी में होती है या इसका कोई मेजर कॉज क्या है?
Yes, this is the multifactorial. Yes, hereditary. I told you this HLA DQ2, DQ8. So it can run in the families. It's not autosomal disease, but it is the some mutation in the level. But sometimes it can present and sometimes not present. I told you that, and it's a multifactorial. When there is a in the family there is a celiac disease and child takes the wheat, it can symptoms will be there or may not, because it can be silent disease, latent celiac disease. Yes, you can say that this is the inherited disease, but not autosomal. It is some type of the gene mutation, gene changing. G.
Thank you, sir.
Thank you. Anybody? Anyone? G. No question? Okay, thank you.